Good afternoon, all. We'll continue on with our spinal cord injury lecture series. Last week, we spoke about autonomic dysfunction and sympathetic reflex activity. This week, we're going to talk about musculoskeletal reflex activity. So spasticity after spinal cord injury. We will talk through a little bit of the definitions and the epidemiology that goes along with that. Obviously, we'll be reviewing some anatomy and physiology, both for muscle innervation, but as well, we will talk through the clinical evaluation of spasticity and then talk about management options. So just as a starting point, spasticity is increased muscle tone that is velocity dependent. That means the faster you move a limb through its range of motion, the more resistance you encounter. It is velocity dependent. Hyperreflexia, first we just need to go back and remember what Sherrington's final common pathway was when we talk about musculoskeletal reflexes. What we're talking about is afferent information from a muscle that's been placed on stretch, ascending to the cord and then sending efferent information back down along alpha motor neurons to that very same muscle that causes a reflex contraction. Under normal neurological conditions, we keep our reflexes in check through supraspinal inhibition. So information coming down, particularly from the dorsal reticulospinal tract and from the ventromedial reticular formation in the medulla, sends, this is inhibitory information to all of those reflex pathways that fall below that level at the spinal cord. After a spinal cord injury, you've lost that inhibitory input, and so all myotomes below the level of the injury are going to be at high risk for hyperreflexia. They've lost the inhibition, supraspinal inhibition, that typically keeps them in check. So as a reminder, again, you have afferent information coming, and we're going to talk through the muscle spindles in just a moment. That afferent information comes in through the dorsal horn of the spinal cord, and it interacts with an alpha motor neuron through interneurons here within the cord. So the alpha motor neuron, remember the cell body arises from the anterior horn of the cord, comes back down to the same muscle to cause muscle contraction. So that stretch reflex, when uninhibited, becomes hyperreflexic, and we see spasticity associated with that velocity-dependent tone. In persons with spinal cord injury, this ranges between 40 and 70%. Fred Maynard reported back in 1990, the level of spinal cord injury is associated with the likelihood of spasticity. So folks with tetraplegia, that is cervical spinal cord injury, almost 90% had significant spasticity. But when you look at folks with paraplegia, only about 50% of those, and the lower down you went, the less likely you were to see spasticity. Part of that is because as you get down to the very lowest regions of the cord, you also have the cauda equina coming off, and you are much more likely to have a conus medullaris syndrome or a cauda equina injury, in which you have either the afferent and or efferent loops broken. The cauda equina is a lower motor neuron. So upper motor neurons, basically we have to remember, are coming down through the cord, and they interact with lower motor neurons that include the peripheral nerves to the muscles and the sensory nerve back from the muscles. So at the very lowest level of the cord, which ends at around the L2 vertebrae, you also have quite a few lower motor neurons coming down from there. And so if you have damage at that area, you're essentially blocking completely this final common pathway. so that you have a flaccid paralysis instead of a spastic paralysis. So how often do we have to treat this? At the time of discharge, and again, this was back in the 90s when we had a bit longer for our folks with spinal cord injury in the acute rehabilitation phase. At the time of discharge, about a quarter of them, 1 out of 4, required treatment. But if you looked at 12 months after the injury, generally about 50% of those folks would require some sort of intervention to keep their spasticity in check. That is, it had become problematic. So now the epidemiology trends make sense. We just talked about that when you take it down to the cellular level. So again, muscle spindles. Muscle spindles lie in between extrafusal fibers. Extrafusal fibers are the ones that we typically think of as contracting with regard to a motor unit. Remember that motor unit is the alpha motor neuron and all of the skeletal muscle fibers, extrafusal fibers, that it innervates. Now, the muscle spindle is an organ within skeletal muscle, and that organ has basically a nuclear chain and a nuclear bag. Both of those have afferent organs, basically, or pick up afferent information, send information back to the cord. And so part of that comes from the 1A afferents of the nuclear bag, and some of those come from the type 2 afferents that are on the nuclear chain. So this organ, what does it respond to? When you stretch the muscle spindle, it activates these sensory fibers and increases the impulses both up along the 1A afferents as well as the type 2 afferents. So what? Those go to the cord, and they interact then through interneurons to the alpha motor neuron back to the same muscle, the agonist muscle. And so those come along the alpha motor neuron, which is typically what we think of as innervating the extrafusal fibers, but you have a concurrent and concomitant activation of the gamma motor neurons. The gamma motor neurons come to the ends, each end of the muscle spindle. And so as the extrafusal fibers contract, the intrafusal fibers on each side of the sensory organ contract to maintain the sensitivity or the gain of the muscle spindle. So these are important aspects in order to be able to maintain some degree of tension and sensitivity as you change the muscle length. Now, I want to talk through upper motor neurons. Basically, you've lost inhibition to these reflex arcs. And I'm going to focus first just on this reflex arc. This has to do with the stretch reflex. So if I tap the patellar tendon, okay, to the quadriceps muscle, that is an extensor muscle, and the spindle afferents, the type 1A and type 2 afferents, information comes in through the dorsal horn of the cord and then interacts with the alpha motor neuron back to the quadriceps, the extensor muscles. As it does that, this is an excitatory synapse. What does that mean? So you have the axon hillock. So this is an axon of the agonist muscle, the extensors. This is an axon to the hamstrings or to the knee flexors, all right? So you see this excitatory synapse is occurring because you have excitatory postsynaptic potentials, EPSPs. Those are modulated by a neurotransmitter glutamate that changes the inflow of sodium and hypopolarizes this. So this makes this more likely for this alpha motor neuron to fire. Remember, it's all or none. That's the way alpha motor neurons work. And yet, what's happening at the axon hillock is that you have a summation of all the excitatory postsynaptic potentials and inhibitory postsynaptic potentials that are presented to this axon. And it requires a certain level of excitability for that to fire. Now, the inhibitory postsynaptic potentials in the same scenario are going to affect, in this case, the antagonist muscle group, but realize that both neurons have axon hillocks, and they are constantly receiving EPSPs and IPSPs. Excitatory postsynaptic potentials make it more likely for that axon to fire. Inhibitory postsynaptic potentials modulated by GABA aminobutyric acid hyperpolarizes and makes it less likely that this will fire. And so all of our alpha motor neurons are constantly being barraged by EPSPs and IPSPs. And whether or not it fires depends on the relative amount of those EPSPs and IPSPs. Why is that important? That is important because this is how we can pharmacologically manage these, the amount of spasticity that we have. We can try to decrease the EPSPs. We can try to increase the IPSPs, and that's going to be important as we talk about pharmacological treatment options down the road with regard to spasticity. So again, the axon hillock is where you are summating all of those excitatory postsynaptic potentials, inhibitory postsynaptic potentials. Is it high enough to fire? So it's all or none. And if it's none, then it doesn't fire and you don't see anything. So if you have damage to this, for example, lower motor neuron, you won't see reflex activity. You'll have, again, a flaccid paralysis associated with that. So when we talk about neural mechanisms for spasticity, velocity-dependent muscle tone, we go through periods following a spinal cord injury of spinal shock, a loss of supraspinal facilitation and inhibition. We develop a denervation suprasensitivity, so the post-neuron receptors become increase in sensitivity and increase in number, so that it's more likely that if they do get firing there, they are going to fire in a big way. And then hopefully we develop motor recovery. Now, spasticity per se isn't always bad. And I think that that's one of the things that we need to remember. Spasticity will occur over time as a person emerges from spinal shock. And then ultimately, the person may be able to use the spasticity and the relative muscle spasms to facilitate movement, and that can be a good thing. However, the spasticity can also become problematic, causing them to push themselves out of their chair, to have their legs spasm repeatedly at night, for example, keeping them awake. So that would be problematic. And one of the things that we're going to have to determine relatively early on is, are we going to allow a certain amount of spasticity to maintain some muscle mass, to maintain some bone mass, and yet the person may use some of that for mobility and activities of daily living, but it also, the spasticity can be interfering with function, and that's going to be one of the things that we have to clinically assess. So we have essentially 5 different ways that we look at spasticity and report it to assess it. We look at the clinical history, we look at the stretch reflex examination, we do a passive motion evaluation and then an active motion evaluation, and then we want to look at functional abilities. So one of the first things we want to know is, what are the triggers for causing spasticity? And again, are those spasms useful? If not, are they interfering with position? Are they increasing pain? Are they associated with pain? Are they worsened with pain? Most likely, yes. Are the triggers predominantly a flexor or an extensor type of spasticity? And usually that has to do with upper extremity versus lower extremity spasms and function. And then finally, is the spasticity, the spasms that are occurring, are those interfering with the person's sleep? If you don't have good sleep, that also makes you, not just you, but in general, not just irritable, but it increases the EPSPs that are sensed, again, by all of these myotomes below the level of the spinal cord injury. So as we assess, we take a history and we ask the person, how frequently are you having spasms? If they say, I'm not having any spasms, then we list this as a 0 on the Penn spasm frequency score. A 1 is that they don't typically have spontaneous spasms, but if they rub their legs briskly, for example, that could cause a spasm, but they don't have spontaneous spasms. A score of 2 on the Penn spasm frequency score means that they occasionally have spontaneous spasms. Those are relatively easily induced. And so here in Miami, we have a lot of people that wear short pants. They have hair on their legs. As the wind blows the hair, that can actually facilitate spasm for that individual. And so that would be occasionally spontaneous spasms, or if they're having more than 1 but less than 10 spontaneous spasms an hour, then we would rate that or score that as a 3 on the Penn spasm frequency score. Again, this is just one mechanisms by which we score spasticity. If they have more than 10 spontaneous spasms an hour, then we score them as a 4. And usually a score of 4 is considered problematic. Sometimes a score of 3 is problematic. That said, we also want to take a look at their reflex exam. And so we will actually do a tendon jerk reflex, and we report that out as normal is a 2+, 1+ is less than normal, or absent is a 0. Hyperreflexia is a 3+, and then clonus is 4+. Now, what is clonus? That's when you have hyperreflexia on both sides of a joint. So typically we push the foot up, for example, in what we call, a plantar flexor stretch. And what we are doing is putting the plantar flexors on stretch, wanting afferents from the gastroc-soleus complex go up to the cord, back down by alpha motor neurons to that same muscle group and cause contraction, which then causes you to plantar flex the foot, which puts the dorsiflexors on stretch, and their spindles send information to the cord, which sends information back to the tibialis anterior and causes dorsiflexion, which puts the plantar flexors on stretch back and forth. So this back and forth hyperreflexia on both sides of the joint is typically referred to as clonus. And many of our folks will be sitting there in our wheelchair and activate clonus so that their leg is bouncing. And I know that first participants in somebody with paralysis is thinking, oh my goodness, they are moving, they're not paralyzed. But what they're doing is just activating those reflexes. And so we need to recognize, but it's comforting to see their limb move, and they actually enjoy that bit of a rhythm and just watching their legs move, for example. So the other thing that we'll do is the Babinski maneuver, where we basically scrape along the lateral edge of the sole of the foot, and we look for an upgoing toe. And that's in response to that Babinski maneuver. The equivalent of that in the upper extremity is called the Hoffman's. And so if a person has a cervical spinal cord injury and you flick the middle finger, it will cause their thumb to flex. And we call that the Hoffman's response. So that said, those are the reflex responses. We talked about the spasm score. Now we want to talk about passive motion. And I'm going to jump past the Ashworth scale because typically this is not the one that we use. We typically report the modified Ashworth score, which is essentially the same, but we score it just a little bit differently. So a 0 means that the person doesn't have any increase in tone. As I move the leg, for example, through its range of motion, I don't encounter any resistance. And it doesn't matter if I do that slowly or quickly. If, however, I get a slight increase in tone at the very end of the range of motion, then I'm going to score that as a 1 on the modified Ashworth scale. A 1 plus is that I get a slight increase in tone with a catch, followed by minimal resistance throughout the remainder. So this is about half of the range of motion. As I'm going through, I have that resistance, not just at the very end, but now, a little bit more than halfway through. A 2 is I have a marked increase in tone throughout most of the range of motion, but I can still move the affected limb relatively easily. A 3, now I've got significant tone. And if you watch me as I'm assessing the patient, you see that I'm working pretty hard to move the limb through its range of motion because I'm encountering resistance both through extension because of the hamstring contraction or spasticity. And then as I try to move it back into a flex position, I encounter a significant amount of resistance from the knee extensors. So if I'm encountering that kind of resistance, then I score that as a 3. A 4 is when the affected part is essentially rigid in flexion or extension, and it's sometimes difficult to determine if this is truly a modified Ashworth scale 4, or if the person has contracted muscles. Now, what does a muscle contraction mean? If the muscle is in a chronically shortened position, it actually reduces the number of sarcomeres that are in series. And so essentially you end up shortening the muscle. If you want to get that muscle's length back to normal, for example, you're going to have to do that through stretch and hold. And so we'll talk about serial casting in a few minutes. Stretch and hold. And this is, it requires a period of weeks and months to essentially rebuild new sarcomeres in series for that muscle. So more on that to come. The next thing I want to do is, I've already assessed the passive motion and resistance to passive motion. Now I want to see what the person can do actively. So this is going to be a person who has an incomplete spinal cord injury. I want to know how well they can move the limb through their voluntary activation of the muscle. This is a little tricky sometimes because the person's spasticity on the antagonist muscle group can interfere with their ability to voluntarily move the limb through its full range of motion because they're resisting on the opposite side. And so I will try to stretch both sides of the limb before I have them do an active muscle contraction because I want to try to get a feel for just what their strength is in the agonist muscle group. Sometimes they will use tone to assist their strength. And so, for example, I had a chief resident when I was an acting intern at UC Davis who had a C7 incomplete spinal cord injury. It was listed as a Asia Impairment Scale C, which means less than half of the muscle groups below the level of the injury were able to work against gravity. So the majority of muscle groups below the level of the injury had a score less than anti-gravity strength. He could actually tap his legs and stand using his spasticity and spasms to facilitate that standing position so that he could come to the bedside, do an examination on a patient, and then slip back down into his wheelchair. But he didn't have active strength to do that. And so he actually used his tone to assist him with mobility. So we want to know, number one, before I start to treat spasticity, is it helpful? Is the person actually being benefited by the spasticity? Or is it interfering with self-care? Is it interfering with sitting? Standing balance? Is it interfering with mobility? Is it interfering with sleep? So all of those things are things that I want to do with my active motion and functional evaluation. So I talked last week about autonomic dysreflexia and all of the nociceptive input below the level of the injury for those with injuries T6 and above that would cause a reflex outflow, a sympathetic reflex outflow, and hypertension. All of the same things that we talked about last week are considered noxious stimuli below the level of the injury. For persons who have spasticity and tone, each of these nociceptive inputs increases the EPSPs at the axon hillock for all of those myotomes below the level of the injury. And so a person with an ingrown toenail, and let's say they have a T6 injury and above, they will not just get autonomic dysreflexia, but they will also have, because the EPSPs, increased tone, increased spasticity because of that noxious stimuli below the level of the injury. For those folks with injuries below T6, however, they might not get autonomic dysreflexia, but all of these things could cause a fracture in the lower extremity, could cause spasticity. They wouldn't get autonomic dysreflexia because it's below the level of T6, below the level of the greater splanchnic nerve. But the noxious stimuli is still going to increase the EPSPs and increase spasticity and tone below the level of the injury. So just like autonomic dysreflexia, if you see increased spasticity for somebody who had previously been well managed, not having problematic spasticity, and suddenly it's flared up, you need to start looking for what is the noxious stimuli below the level of the injury. And it's most likely the bladder or the bowel. So the number one cause of spasticity, new and different than usual, is a bladder. And the number two cause of spasticity that's new and unusual is the bowel. So we just kind of keep those things in mind. The nice thing is they fall right into line with what we learned about autonomic dysreflexia. So when do I treat? If the spasms are harmful, interfering with position, if they're interfering with activities of daily living, if I can't spread the person's knees apart to be able to do perineal hygiene, then I need to be considering managing that spasticity. If the person is not sleeping because of nocturnal spasms that occur at night, and particularly if those spasms are painful, pain increases EPSPs, and so that becomes a vicious circle. And so we need to do what we can to manage that. We used to only think of spasticity in a very sequential model, removing noxious stimuli and then using different modalities to manage, basically by changing the sensitivity of the spindle fibers, and then using oral medications, intrathecal medications, considering neurolysis, and surgical options. The newer model says you don't have to do this sequentially. You could consider using a couple of things at the same time, depending upon the person's circumstances and what is available to you at the time. However, most folks would say, yes, surgical intervention should be one of the last options as we move forward. So I'm going to talk you through the stepwise sequence, recognizing, again, we are no longer tied to, has to be done in this order. Physical modalities, one of the first things we can do is to increase the passive stretch. What does that do? That slowly changes the sensitivity of the spindle fibers so that you have less spindle activation and less 1A afferents going up. Therefore, you have decreased EPSPs because you have slowly stretched the muscle and slowly changed the gain of the spindle fibers. Now, the problem with this is it wears off. And so your stretch will work for, an hour or so. And yet the spindles tend to come back to their original state of sensitivity and gain. So they, remember, changes in muscle length are going to activate the spindles. And so you can use stretch in the short term to reduce the EPSPs, and therefore the likelihood that an alpha motor neuron is going to fire. We can also use this technique, stretch and then hold by casting or splinting the limb at that stretched length for a period of time. And then usually over weeks and months, when we do this, we look to, again, increase the number of sarcomeres that are in series for that muscle to be able to regain some range of motion that had been lost. Posture and positioning. So wheelchair seating can really facilitate or worsen spasticity. If you are not sitting in an optimal posture, that's going to increase the likelihood of a noxious stimuli below the level of the injury. So some of us have problems with our back. If you're caught in a posture in a wheelchair that causes that back pain, the person might not feel that, but that pain increases the EPSPs to all of those myotomes below the level of the injury and makes it likely that they're going to fire the alpha motor neurons. That is, the noxious stimuli is causing increased EPSPs. And so by positioning the person appropriately in the wheelchair and repositioning intermittently, you decrease those EPSPs. You decrease the noxious stimuli to all of the myotomes and therefore all of the reflex arcs below the level of the injury. So we are going to be using tilt. We're going to be using, depression lifts, different things that we can do to try to minimize the EPSPs, excitatory postsynaptic potentials, that would come about because of prolonged sitting in a painful situation. Again, the person doesn't experience pain, they just increase spasticity. We can use cryotherapy also to decrease the muscle spindle sensitivity. And so 15 to 20 minutes of cryotherapy ice will decrease intramuscular temperature, decrease EPSPs. This potentially is also going to decrease cutaneous nerve sensitivities. We know that cooling muscles and cooling axons also reduces the nerve conduction velocity, makes it less likely that this is going to fire. However, recognize that you can actually cause skin damage that the person doesn't feel, and you could actually then cause more spasticity. So this is something that we use very cautiously, using both ice and heat. Needs to be done very carefully for folks who are insensate at those levels of application. So what I don't have is I don't have any controlled studies evaluating the long-term impact of cryotherapy, for example. And so, again, this wears off almost as quickly as stretch wears off as we go through this. And so you would have to apply frequently in order to be able to maintain or to have some control over your spasticity. Electrical stimulation can work in a couple of ways. If it reduces painful stimuli, I have a whole separate lecture on the use of functional electrical stimulation and TENS, transcutaneous electrical neuromuscular stimulation. We know that that can be used as white noise, essentially, to block pain. So the gate theory of pain basically is going to decrease the excitatory postsynaptic potentials and therefore decrease spasticity. It's also possible that when used in the antagonist muscles, you could actually increase IPSPs to the agonist muscle. So a couple of different ways in which electrical stimulation can modulate spasticity. But I'm going to spend the rest of our time talking through the essentially pharmacotherapy. How can we manage, using what we know about EPSPs and IPSPs, how can we manage spasticity? So I'm going to talk you through the GABA agonists. Remember that GABA and things that work like GABA are going to increase the inhibitory postsynaptic potentials at all of the myotomes below the level of a spinal cord injury. And the GABA agonists that we'll speak about, lioresal, baclofen, and then the benzodiazepines. And then we're going to talk a little bit about gabapentin, which is supposed to be a GABA agonist, but it isn't really. We'll get there in a moment. In addition to increasing the IPSPs, we can look at ways to pharmacologically reduce the EPSPs. And so we can use our alpha agonists, and I'll talk you through clonidine and tizanidine. And then the other thing that we can use, used more so for brain injury, cerebral palsy, those types of things, is dantrolene sodium to uncouple the excitation contraction complex. And we'll talk you through why that works, but why it's not a great tool for persons with spinal cord injury under most circumstances. So the GABA agonists, and I'm going to start with baclofen. The oral medication basically is a GABA analog with a half-life of about 3.5 hours. Its mechanism of action, again, it's going to increase the inhibitory postsynaptic potentials by hyperpolarizing the membranes. So we typically start with a dose of around 5 milligrams 3 times a day. The physician's desk reference say that we shouldn't be using more than 80 milligrams a day. Most folks that have worked with spinal cord injury for some time recognize that you can actually go up higher relatively safely, but what you do as you increase the dosage, you're likely to increase sedation and the relative sense of fatigue and weakness. You're also, because you're reducing spasticity and tone of the muscles, very likely to cause a reduction in blood pressure. And so their blood pressure may go down as you manage their spasticity. One of the major drawbacks of using baclofen is that if you abruptly stop it and you're at doses of 10, 3 times or 4 times a day or more, you are possibly going to provoke seizures and hallucinations. So we caution folks not to run low on this medication. Make sure that they get their refills well in advance. We know that this medication decreases the seizure threshold, makes it more likely that a person would have seizure. And so again, for someone with brain injury, for example, with seizures, not a good, not the best option to use. So nonetheless, one of the first line medications that we use for somebody with spinal cord injury, problematic spasticity. Diazepam, also known as vitamin V, Valium, is also a GABA agonist, but instead of, so the baclofen, and that easy way to remember, works on GABA B receptors because of baclofen, GABA B. The Valium works on GABA A receptors. And so it has influences centrally as well. And so a lot more sedation associated with the use of diazepam. However, like the GABA B agonists, baclofen, diazepam is going to increase the IPSPs. So this is a great medication for folks who have primarily nocturnal spasms because it makes them sleepy, and it also decreases their spasticity while they're trying to sleep at night. Similar side effects as associated with baclofen, sedation, relative low blood pressure, weight gain. Now, I just have to say, anytime that you start to treat spasticity, that spasm, that the spasticity and tone has maintained some muscle contraction. Muscle contraction burns energy. Energy burns calories. And so when I start treating somebody for spasticity and they're like, yes, my spasms are gone, I have to also say, but be careful, because you're going to have to decrease your energy intake or you're going to gain fat weight. Whole nother lecture. We'll get past that. However, spasticity, did I mention, is not always bad. And that's one of the things that is on the good side. So recognize as you use any anti-spasticity medication, you're going to put the person at higher risk for a positive energy balance, that is weight gain, which is not necessarily a good thing. Now, gabapentin, you would think gabapentin, that should work on GABA receptors, but it actually doesn't. It doesn't interact with them at all. It might inhibit the voltage-sensitive calcium channels, but more likely the reason that gabapentin works is because of its neuropathic pain alleviating properties. It actually decreases EPSPs. And so even though it's called gabapentin, it doesn't work on the GABA receptors and it doesn't increase the IPSPs. It likely reduces spasticity because it reduces afferent pain signals. That is, it decreases the EPSPs. And again, starting doses, 300 milligrams TID for a relatively young individual. Now, if I have somebody in their 80s who is having neuropathic pain, I'm not going to start with a dose of 300. I'll start at 100 and then increase slowly, for example. Side effects, again, in addition to the sleepiness, the somnolence associated with this, they may have some dizziness as their blood pressure drops in response to this. I'm going to talk through the alpha agonists. So the alpha agonists don't increase IPSPs. They work on a completely different mechanism. They facilitate the inhibition of the H reflex by reducing the glutamate. They decrease the excitatory postsynaptic potentials. And so clonidine is one that is used, although traditionally we use clonidine to manage blood pressure. And so for our folks who have neurogenic orthostatic hypotension, we talked about last week, this is not going to be a good medication for them because it's going to likely cause their blood pressure to drop even further. However, it will reduce their spasticity. A better option as an alpha agonist is tizanidine. And again, it works in the same way, but it doesn't have the profound blood pressure lowering effects that clonidine does. And so again, decreasing the EPSPs, you can use this in conjunction with baclofen, for example, because they work by different mechanisms. Baclofen increases the IPSPs and tizanidine decreases the EPSPs. And so those are medications that I consider using in concert. But again, I try to reduce the total of medications that I'm giving to any individual at any given time. And so if I can only manage with one medication, I would choose typically baclofen. Tizanidine is a good option for those folks who don't tolerate the baclofen well. And then again, remember your excitation contraction coupling. So you have your T-tubules and your sarcoplasmic reticulum. The sarcoplasmic reticulum releases calcium, and calcium activates the troponin tropomyosin complex. Well, dantrolene sodium basically blocks the release of calcium from the sarcoplasmic reticulum, but it does it at all muscles. It doesn't just work on reflexes. It works at the muscle themselves. And so if I put somebody on dantrolene, I have to realize that I'm also going to reduce their strength in their voluntarily activated muscles. which is usually not a good option for our folks with spinal cord injury. So in severe cases, I will consider using dantrolene, but usually we have better options. Dantrolene is going to affect the liver function test, the liver enzymes to a much greater extent than these other medications. I do monitor liver function for folks on Baclofen, for example, and tizanidine, but especially if I'm going to use dantrolene, I want to have a baseline, and then I'm watching very carefully as I titrate the medication upwards to have an effect. So intrathecal Baclofen, for those folks that get really somnolent, really sleepy, or are having side effects associated with higher doses of oral Baclofen, intrathecal Baclofen can be a great way of doing this. And instead of having to take medications all day long orally, we could provide an intrathecal Baclofen pump that basically puts the medication right into the cerebral spinal fluid that bathes all of these alpha motor neurons as they're coming down. So basically, we are increasing the IPSPs as we go along with that. To do an intrathecal Baclofen trial, basically, we do a lumbar puncture and inject a relatively small dose. Some folks will start with 50 micrograms. Usually, I go with 75 for spinal cord injury. And the reason is if I start with 50 and I don't see a response, then I don't know for sure if the person might have responded at a higher dose. 75 is kind of that in-between zone for me, but if a person doesn't respond to that, I still might go up to 100 micrograms on a second trial. The trial itself usually lasts about 4 hours, and we're going to look for a 2-point drop in the modified Ashworth scale of the limbs that we're looking at. But I'm also looking for changes in mobility, changes in activities of daily living, changes in perineal hygiene. Those types of things can actually be much more helpful to decide if a person is going to benefit from intrathecal Baclofen as opposed to otherwise. There are certain contraindications, and I don't have a lot of time to go into this, but obviously, a person with an allergy to Baclofen, I don't want to fill their cerebral spinal fluid with Baclofen. That would be suboptimal, yes. Relative contraindications, those who have psychosocial issues that could limit their follow-up. Again, we don't want to have an abrupt withdrawal of Baclofen because they didn't come in for a refill. So similar to those with psychiatric history, inadequate body mass, and those who are likely to become pregnant, although depending upon how they put up the system, sometimes this is a relative contraindication. Sometimes this could still be helpful for individuals. There is a really nice, these are the older methods of programming the Baclofen pump. The pump itself is about the size of a hockey puck. It lies underneath the skin, usually at the right lower abdomen. And it has a port here for a catheter placement. You can actually change the settings on the pump in terms of how much Baclofen it will release into this tube, the catheter, that goes into the basically cerebral spinal fluids. And then we can adjust that dosing as we go through there. So again, the catheter comes through here. You put the Baclofen. Typically, they will put the catheter at about the T5 level. It may be a little bit higher for some folks, recognizing that the medication itself is more dense than the cerebral spinal fluid, and so gravity will pull it down. And so if you have somebody with upper extremity spasticity, you're like, oh, well, that's not going to work at all. Well, except that, if you tilt them back in their wheelchair, then it will bathe some of those higher elements in the cord, and they can get some significant spasticity relief after having tilted back for 30 minutes or so. So don't think that that's not a viable option. These are the benefits. You get to use a direct delivery of a high concentration of the medication with relatively few side effects. And you can only, you can go 3 months without having to take oral medications, et cetera, and then refill the pump. The risks, the surgical procedure itself carries some risks. There is less likely that the pump will malfunction, more likely that the program operator might make a mistake and not program appropriately. And then really the other aspects of failure typically have to do with catheter occlusion, dislodgement, or kinking. So you weigh those risks, benefits. We teach our residents that if the person has had a pump, it's been working well, and it stops working, there are a number of things that we want to consider. And we go through this process along typically with our neurosurgeons or the physiatrist, pain physiatrist who may have placed the pump with us. We may end up going to dye studies. That's a little bit further on the realm of this. Similarly, if somebody comes in, pump is beeping, and they are absolutely in withdrawal, then we're going to consider. Now, they may also have an overdose. And again, typically this is a programmer malfunction, usually not the pump malfunction. But if they do have withdrawal, we go through quickly this troubleshooting algorithm. And again, all of our residents should be feeling pretty comfortable so that when they're on call, they know how to manage if somebody comes into the emergency room or they get a phone call. And then, all of our attendings obviously should feel comfortable with these algorithms as well. And I think that we need to update just at least once a year, just so everybody is in tune and recognizes how this goes. I don't have a lot of time left. I'm going to talk briefly about neurolysis. And essentially, this is blocking motor function of the peripheral nerves. And so we can do a test trial with an anesthetic, lidocaine, for example, bupivacaine. But we're going to be doing usually one of two things. Either we're going to be doing chemical neurolysis of the motor nerve itself. You don't want to do this to a mixed nerve because it can cause neuropathic pain in sensory fibers. So mixed nerve has sensory fibers. But for example, if you're looking at difficulty with a lot of spasticity in the lower extremity adductors, for example, you could use phenol injections to essentially lyse the motor nerves, the obturator nerve branches to the adductor muscles, and you don't have to worry about sensory dysfunction. This usually wears off the first time, 6 to 12 months, but with a subsequent 1 or 2 more times, typically you can get pretty good long-term response with this. Botulinum toxin, I'm going to briefly run through this video, or maybe I'm not. Let's go back for a second. My video typically plays, but it's not going to work this time. So the bottom line is botulinum basically works presynaptically. And what it does is it blocks the release of acetylcholine into the neuromuscular junction. And I'm sorry, there it comes, finally.
The presynaptic neuromuscular nerve ending contains membranous vesicles prepared to release its stored neurotransmitter, acetylcholine. Neuronal stimulation initiates a cascade of events that leads to the fusion of the neurotransmitter-containing vesicle with a nerve membrane. This process is facilitated by a group of proteins comprising the snare complex. The membrane fusion results in the release of acetylcholine into the synaptic cleft by a process of exocytosis. The acetylcholine diffuses and eventually binds to receptors on the muscle, leading to muscle contraction. Botox, botulinum toxin type A, consists of a heavy chain of 100 kilodalton and a light chain of 50 kilodalton, making up the 150 kilodalton core type A molecule. The toxin is protected by accessory hemagglutinin and non-toxic non-hemagglutinin proteins, yielding a uniform 900 kilodalton complex. This illustration shows a cross-section of the spine with a motor neuron extending into the muscle and a sensory neuron extending out of the muscle. After injection of Botox, it would be expected that most of the neurotoxin would remain at the injection site. The Botox core molecule dissociates from the accessory proteins and targets the nerve endings. The binding domain of the Botox core molecule is the C-terminal portion of the heavy chain with an acceptor on the nerve. The Botox core molecule enters the nerve cell by a process of receptor-mediated endocytosis. It is the heavy chain that contains the binding domain. The toxin is now contained in a membranous vesicle inside the cell. Soon after, the light chain is released into the cytoplasm of the nerve terminal, where it begins to cleave one of the snare proteins. In motor neurons, the light chain of the Botox core molecule blocks the release of acetylcholine by cleaving SNAP25, which is an essential component of the snare complex. When acetylcholine cannot be released, muscle contraction cannot occur.
And that's the bottom line on how Botox works. We recognize that its peak effect is typically within 2 to 4 weeks. Usual duration of action is somewhere around 3 months. We can localize it to a specific muscle group. The thing is, this is not for somebody who has many, many muscles that are being affected. It's a much better option for folks who have very focal spasticity and spasms. There are some drawbacks. Once you give the toxin, that nerve basically is going to be paralyzed, or the muscle is going to be paralyzed for approximately 3 months. We do worry about the potential of antibody-mediated resistance. And then finally, there are surgical interventions. If nothing else has worked, you can actually cut, so doing a selective dorsal rhizotomy. This is the afferent going into the dorsal horn of the cord. And basically that is breaking the Sherrington spinal common pathway. There are other surgical procedures that are even more invasive. This is the one that's typically used, but not usually used for persons with spinal cord injury. More of the time, this is for significant cerebral palsy, for example. So the bottom line is spasticity results from a decrease in supraspinal inhibition, so that there is ultimately a decrease in the inhibitory postsynaptic potentials at any alpha motor neuron below the level of the spinal cord injury. And it increases the likelihood of noxious stimuli below the level of the injury that increases the EPSPs. Spasticity can be beneficial, but it can also be problematic. Management includes removing the noxious stimuli. That would be ideal. Using physical modalities to try to change typically the gain of the muscle spindle apparatus. Medications that either increase the IPSPs, such as the GABA agonists, or decrease the EPSPs, such as the alpha agonists, and then intrathecal as opposed to an oral route of administration may be optimal for some individuals. In more severe situations, using a neurolysis either through phenol or botulinum toxins can be used. And then worst case scenario, moving on to surgical ablation, typically selected dorsal rhizotomies can occur. So I've kind of taken up my whole hour. I have all of 2 minutes for questions. And so feel free to ask any questions that might still be there. Dr. Vivas usually has at least one.
I have a question.
Yes.
Thank you for the lecture. So, and now knowing about the IPSP, EPSP in a patient that is relatively well controlled in Baclofen, but is complaining of nighttime spasm, what will be your next management? Increase the Baclofen or add Valium or tizanidine?
I might, if they're really having problems sleeping, are they on 3 times a day or 4 times a day of the Baclofen? So 3 times a day, I might go to 4. Or if it's, relatively early in the course, I might just try it just a nighttime dose, and I would probably start at 5 or 10 milligrams of Valium. Usually I don't do the 2 at the same time, but if I've only got 3 times a day, the Baclofen, and that's working well for the person during the day, then just adding the Valium at night can be very helpful. I should say Diazepam, yes.
All right, thank you.
Any other questions, thoughts, concerns? Gripes, groans, psychic moans? All right, everyone have a wonderful day. I guess I'll see you again next week. Until then.